everybody. Welcome to StoneSmart Live. So StoneSmart is a Boston Scientific thought leadership program focused on cultivating conversations about your most challenging stone cases. And the StoneSmart Forum is an interactive site on Urology Times, where you can view case studies and discuss challenging urology issues with all of your peers as you advance the science of endourology. Now, we are here at the 2017 World Congress of Endourology in Vancouver, of course, for a discussion of some of the cases that are featured on stonesmart.urologytimes.com. Now, this month on the StoneSmart Forum, Dr. Roger Sir demonstrates how he treated a Staghorn stone ureteroscopically. Unfortunately, he can't be with us today because he is performing surgery that you can view on a live session at WCE. But he has taken a few minutes out of his day to talk with us via FaceTime from San Diego. There he is. So, hello, Dr. Sir.
Hello, Vancouver. I'm so sorry that I can't be there, but I look forward to joining you after these cases.
Well, we're sorry too, but we appreciate you joining us this way. Now, Roger Sir is director of the Comprehensive Kidney Stone Center of the University of California in San Diego. Dr. Sir shared a case of a morbidly obese man with limited access to care who presented with a Staghorn stone. He first attempted PCNL, but had difficulty getting access. So when his patient developed respiratory problems during the procedure, Dr. Sir aborted the case and later attempted ureteroscopy. Now, I would like to play the section of the case that illustrates this ureteroscopic attempt to treat the stone.
So plan B was staged ureteroscopy, and as you probably know, it's often not the first-line treatment according to our AUA guidelines, but it is an option in the most recent guidelines. So we took him back for ureteroscopy, and whenever I have a Staghorn or a large stone that I'm going to do dusting, I typically do put up an access sheath. I love access sheaths for this reason because you can irrigate and improves visualization. A lot of the fragments will then pass down alongside the scope. I think it really expedites the procedure. It also decreases pressure, backflow. If there's any potential infectious risk, I think that infectious risk might be mitigated by using an access sheath. And then I take the laser settings and I use a dusting type setting, which is like low 0.2 joules, and I ramp up the rate to about 40 or 50 hertz. And we just sit there with the scope and just go to town. There's no basketing. I don't like to laser for more than 2 hours, especially a large stone that I think that might be an infectious risk. I think it does increase their risk of perioperative infectious complications. So with the access sheath, limited operative time, get in, stent them with a plan to come back. And I always lower the expectation. I tell them it's going to take several procedures here, okay? So after I did my post-op CT, I was surprised to see that he didn't have much stone.
So that's a great outcome for such a challenging case. Dr. Sir, what are your indications for ureteroscopic treatment of large stones like this?
So typically, the guidelines recommend a percutaneous approach for a very large stone greater than 2 centimeters. So your question is, when would I use ureteroscopy instead of PCNL? Mm-hmm. And the indications in my mind are patients who are not good candidates for PCNL. For example, if a patient doesn't tolerate the prone position, typically there's some pulmonary or cardiac reasons that would make them a poor candidate for the prone position. That's one of the major indications. And then the other indication is if there's preference from either the surgeon or the patient, if there's a shared decision that they agree that ureteroscopy is more ideal, then that's another indication.
All right, well, in terms of that shared decision, for a really large stone or situation like this, how do you present the trade-offs between PCNL and multiple stage ureteroscopy?
Well, I have a personal bias towards a percutaneous approach, and for that reason, I tell the patients I have a bias towards that, and it is supported by the guidelines, and I tell them that the benefit from a percutaneous approach is that your stone-free rates are going to be excellent. However, there is a morbidity or risk of an adverse event that's associated with PCNL, and the literature does suggest that, or does support the fact that the complications are potentially more devastating. With that being said, I tell the patients, look, in the hands of a high-volume surgeon, your chances of a complication have been minimized, are still present, but they're minimized. And for that reason, I feel a percutaneous approach, an invasive approach, is justified.
Absolutely. Now, you mentioned that you typically utilize an access sheath for a Staghorn stone. Are there times that you don't use a sheath? And if so, when do you use one versus not use one?
So I like to use an access sheath because that's my preference. However, I know many surgeons that would not use an access sheath. But again, I think it comes down to surgeon preference. And the reason I like it is for the purported advantages of an access sheath. One, you have potentially better visualization. There's less intrarenal pressure associated with it. If you need to remove fragments for some reason, you can remove them easily and then re-enter the collecting system. And so for those reasons, I like using an access sheath.
Okay, that sounds good. Now, during the video, you mentioned the laser settings that you typically use for a very large stone like this. Would you ever vary from that? And if so, what cues would you use to alter the laser settings?
I think it's unclear to us as endourologists what the ideal setting is. We know that the setting in general should be a lower joule, like 0.2, 0.3, or 0.4 joules, and a higher rate of 30, 40, 50. In fact, some of the newer machines can go even higher potentially. So it's unclear what the ideal settings are, but somewhere in that range is a sweet spot. And I think for every patient and every stone, there might be some individual differences that the surgeon will have to discover at that time.
Of course. Now, what problems have you encountered when treating large stones ureteroscopically?
Yeah, so again, like I said, with ureteroscopy, complications tend to be less frequent and the degree or the acuity of the complications tends to be lower. However, I have seen some significant adverse events. What comes to mind, I did have a patient who developed a significant perirenal hematoma, and it was probably associated with prolonged surgery and potentially higher intrarenal pressures. The other risk with these large stones that we all know is that they have an infectious risk, so you can develop post-operative urosepsis. So, and I think the common denominator between a lot of these complications is prolonged operative time. So if you can maintain a lower operative time, then your risk will proportionally decrease.
Right. Now, how do you manage patient expectations with these more complicated large stone procedures?
Like everything, I like to undersell and overdeliver. So I will tell the patient, look, if we're going to choose a less invasive procedure, like I mentioned earlier, then there's a good chance you're going to buy yourself at least 2, if not 3, could be even 4 procedures to render yourself stone free. Which is, as long as you're okay with that, I'm okay with that. So I lower the expectation, and then if you get it done in 1 or 2 cases, hey, you look great.
Okay, great. Now, how do you follow up postoperatively in between stages of the procedure?
Yeah, I like to do a procedure, leave a stent in for about 3 or 4 weeks, obtain some type of imaging to reassess the stone burden, and then do another surgery, and again wait 3 or 4 weeks. In that interim, the stone fragments have an opportunity to kind of pass along the stent and migrate out of the body.
Okay. Now, your case, of course, is the featured discussion on the StoneSmart forum this month. Tell me, what's it been like to participate in the StoneSmart forum, and would you encourage your peers to participate in the conversation and share their own case studies?
Yeah, I definitely would encourage my peers to do so. I think it's always fun to share your experiences, and as much as I love to share, I love to learn from other people, and it's irregardless of where they practice, whether it's in the community, another academic setting, even trainees. I feel like I constantly am learning things by talking to other people, and by this type of venue is a great just one more opportunity where we get to share our thoughts, and perhaps we'll give something that will help another urologist and ultimately another patient. So we all have a lot of information to pass on, and it's a wonderful opportunity to use the internet in this way.
It is a great opportunity indeed. Now, unfortunately, our time is up. Thank you so much, Dr. Sir, for a most interesting discussion. And thanks to all of you for joining us. As I mentioned earlier, Dr. Sir's case is featured this month on the StoneSmart forum. You can actually view the full case and join the online discussion. You'll just go to stonesmart.urologytimes.com. And to learn more about Boston Scientific's portfolio of solutions for your most challenging stone cases, please visit bostonscientific.com/stonesmart.